This module focuses on benefit cost analysis, a type of economic evaluation that compares the costs of a program, policy, or intervention to its outcomes. In benefit cost analysis, all costs and outcomes are converted into dollar terms. Economic evaluations are best conducted once a program, policy, or intervention has proven effective, but prior to widespread implementation and dissemination. In this way, economic evaluations are typically conducted retrospectively. However, an economic evaluation is often conducted prospectively, alongside community or clinical trials. Either way, economic evaluations conducted before implementation are the best way to ensure efficient allocation of scarce public health resources. Benefit cost analysis is a type of economic evaluation method where the costs of the program or intervention are compared to the benefits of the intervention, and both costs and benefits use the same units, dollars. Benefit cost analysis allows you to consider all costs and benefits over time, even those beyond the length of the intervention. As is often the case with preventative interventions, the costs of the intervention occur in the immediate future and benefits occur in the distant future. With benefit cost analysis, costs and benefits, regardless of when they occur, are included in the analysis. In addition, because all program costs and outcomes are converted into dollars, you can also consider including non-health outcomes associated with an intervention. If you can assign a dollar value to an outcome, you can include it in benefit cost analysis. For example, a program designed to increase physical activity among seniors living in an adult residential facility may have the added benefit of improving social or psychological relationships. Benefit cost analysis is typically used at the executive level of government when considering regulatory proposals that would be costly to implement, but that would have potentially large economic benefits to society. Examples of these regulatory actions are the Clean Air Act and the Clean Water Act. Application of benefit cost analysis to public health interventions is a more recent phenomenon. There are two common summary measures used in a benefit cost analysis. The first is a benefit cost ratio. To find this ratio, divide the program's net benefits by its net costs. The result is a summary measure that states, for every dollar spent on program X, Y dollars are saved. This type of summary measure is popular with policymakers because it's easy to understand. If the benefit-cost ratio is greater than $1, it implies that the program or intervention produces more benefit than it costs. However, the benefit-cost ratio is somewhat misleading. If you have a negative ratio in which the program doesn't save more than it costs, you can't easily determine whether the negative ratio comes from a negative numerator or a negative denominator. A negative numerator would mean that benefits are listed as negative costs. A negative denominator means that costs are listed as negative benefits. In other words, it's easy to manipulate how costs and benefits are described to get the ratio you want. In the same way, the ratio can be manipulated to show a bigger return on investment than really exists. Again, by labeling costs as negative benefits or labeling benefits as negative costs. Perhaps a better summary measure for benefit cost analysis is net benefits, derived by subtracting net costs from net benefits. In this way, programs show a positive return on investment if net benefits are greater than zero. This summary measure is less easily manipulated in terms of how costs and benefits are labeled, and thus is the preferred summary measure in benefit cost analysis. Benefit cost analysis is used to decide whether to implement one specific intervention or program which can be determined if net benefits are greater than zero. It can also be used when choosing between competing options. In this case, you would choose the intervention with the highest return on investment or the highest net benefit. Finally, benefit-cost analysis is useful when deciding between a whole set of possible interventions with a limited budget. In this case, the net benefits are determined for all the programs. They are ranked in order of decreasing net benefits, and the budget is spent according to the program ranking until the money is gone. Because all costs and outcomes are converted into dollars, the objective ranking of programs by net benefits makes it easy for policymakers to spend a limited budget based on the highest return on investment for society. Assessing program costs in a benefit-cost analysis follows the same methods discussed in the last module. Assessing program benefits in a benefit-cost analysis is a little more challenging than assessing program costs. Benefits of an intervention or program can be considered direct, indirect, or intangible. Direct benefits are those medical expenses saved because of prevention or treatment of the disease or illness. Indirect benefits are those associated with productivity gains because of prevention or treatment. Examples of indirect benefits include workplace interventions that have the direct intent of improving health outcomes, but that may indirectly improve employee productivity, satisfaction, morale, and retention. Intangible benefits such as improved psychological health are also important, but because they are difficult to quantify, they're considered intangible. Valuing the direct benefits of a program, such as medical savings, follows the same methods discussed in Module 2 on costs of illness. Valuing indirect benefits in terms of productivity gains was also discussed in Module 2 using the human capital method. In addition to that method, 3 other methods can be used for valuing benefits in a benefit-cost analysis. The human capital approach for valuing indirect benefits in a benefit-cost analysis is based on the theory of investment. People are viewed as capital investments whose sole purpose is to produce for society at large. The human capital approach assumes that workers have a value equal to their earnings, because the fair market workplace would not pay workers more than they are worth. The value of their production potential in society is based on the wages they earn, including all the benefits associated with those wages. Some adjustments for their production potential within the household are usually included as well. If a disease, injury, or illness affects a person's productivity, the cost to society is valued in terms of lost earnings. Thus, the human capital approach is fairly straightforward when valuing a death associated with a disease. The human capital approach would base the value of a death on a person's age, sex, and occupation, because wages differ by these factors. The present value of future earnings, including gross earnings and fringe benefits, would be adjusted for non-market labor such as household productivity. In some cases, you would subtract future consumption from this value, because these goods and services would still be available to other members of society. You can use tables with calculated lifetime cost estimates using the human capital approach. See the gross chapter in the Haddix reference. Valuing morbidity is a little more complicated than valuing mortality. Simplistically, we could say that the value of losing 5 days from work because of an illness is equal to 5 days of wages, adjusted for fringe benefits and household productivity. But the ability to return to work might have less to do with the disease and more to do with the occupation. For example, if an airline pilot suffers a mild stroke, she may not be able to return to work. But if a professor suffers a mild stroke, she may be able to return to work. Furthermore, returning to work doesn't necessarily mean the same level of productivity. This may be particularly relevant to stroke and heart disease patients. You must value the reduced level of productivity once the person returns to work. Finally, the person might return to work but in a different capacity. The professor may no longer be able to teach in a classroom after having a mild stroke, but she could continue to be a productive academic researcher. Despite its widespread use, the human capital approach for valuing indirect benefits of interventions has many limitations. First, because it's based on wages, it discriminates against low-wage earners, such as the elderly, the very young, the disabled, and women, relative to men of the same age and occupation. Second, it assumes that the labor market has perfect equality, in that people are paid at their true production potential. There are equal job opportunities for all, and people get paid the same wage for the same job. Unfortunately, we know these things aren't true. A teacher's salary may have more to do with the geographic location than experience, quality, or productive potential. Finally, the human capital approach values only the indirect benefits associated with productivity losses and does not incorporate pain, suffering, and losses in leisure time. Here's an example of how you would estimate the indirect benefits associated with a hypertension prevention program that increased productivity. If annual income is $40,000 and the fringe rate is 25%, then total earnings are $50,000. If you assume 250 working days in the year, then the average total earnings, including fringe benefits, are $200 per day. Before the program, participants missed an average of 20 days of work per year, but after the program, the average was only 7 days. Thus, the program gained 13 days of productivity potential per year. The value of this benefit is $2,600. An alternative to measuring productivity loss by the human capital approach is the friction cost method, which is typically used in European economic evaluations. This method is based on valuing productivity loss in the costs required to replace a given worker and the loss in productivity during the time it takes to do so. In the case of a short-term illness, a firm has no production loss if sick individuals make up the lost production on their return to work, or if there is a pool of permanent reserve labor that can cover the sick worker. A firm has a production loss if there is a lasting drop in production while the sick individual is away from work. The sick person's lost production is compensated for by overtime payments on his or her return to work, overtime to colleagues, or temporary workers. In reality, unemployment exists in most societies, so there is always a pool of workers to draw from, and the opportunity cost of labor is zero after replacement. Hence, the value of productivity loss using the friction cost approach should be less than the value using the human capital approach. In fact, in many studies, the friction cost approach comes to 18 to 44% of costs valued using the human capital approach. An alternative to the human capital or friction cost approaches for valuing direct and indirect benefits in a benefit cost analysis is the revealed preference approach. In this approach, you assess market goods to infer a value for non-market goods. The approach is based on real consumer choices for goods that may be similar to the non-market goods under consideration, such as a reduction in mortality risk. For example, we could look into the labor market to see how much people are willing to accept in extra compensation to have an increased risk of on-the-job fatality. This will help us infer how much they're willing to pay for a statistical life. Suppose a person is willing to trade Job A, which pays $40,000 with no risk of death, for Job B, which pays $42,000 with a 1 in 1,000 risk of death. That person is willing to accept $2,000 to take a 0.001 or 10,000th risk of death. Therefore, society, which is defined as 1,000 people, values one statistical death at $2 million. The problem with this approach is that the compensation people are willing to take for increased mortality risk varies widely, based on the context of the occupation. Many other factors may influence these decisions. For example, market imperfections exist where there are no other jobs in the area, so everyone must become a coal miner. This has nothing to do with the willingness to accept the extra risk of death. Another factor is the limited ability to understand occupational risks, which may occur when people join the military. Another alternative to valuing benefits in a benefit cost analysis is simply to ask people to state how much they are willing to pay. This is accomplished through sophisticated survey methodology. Respondents are presented with a hypothetical scenario, such as a risk of cardiovascular disease, and asked how much they would pay for a risk reduction in that scenario, or how much they would have to be paid to take an increased risk. How much respondents are willing to pay is contingent on the scenario presented, so it's called a contingent valuation. Stated preference, although used extensively in valuing non-market goods in environmental health, has not been widely applied in the field of public health, particularly in the field of cardiovascular disease. Here is an example of a benefit cost analysis in the field. This is a study by Cote and colleagues who conducted a benefit cost analysis of a pharmacy-based intervention to improve blood pressure control. The program costs included the time it took pharmacists to take blood pressure and assess adherence to treatment. There were two types of intervention benefits: direct benefits in saved treatment costs between cases and controls, and indirect benefits based on what participants were willing to pay for the intervention. The assessment of indirect benefits assumed respondents were thinking about the decreased risk of complications associated with elevated levels of blood pressure when they were responding to the willingness to pay survey. The authors found that intervention saved approximately $290 Canadian in medical costs, which were the direct benefits, with an additional savings of almost $5 in indirect benefits, because that's what the respondents were willing to pay for a decreased risk of complications associated with elevated blood pressure. Compared with the costs of the program, benefits were almost 10 times greater, suggesting that this program is a good investment. Note that the authors used the two summary measures we mentioned before, but instead of net benefits, they assessed net costs, or costs minus benefits. And instead of a benefit-cost ratio, they assessed a cost-benefit ratio of costs divided by benefits. However, the interpretation of the results is the same. You might also see a return on investment analysis, which assesses the business case model for prevention. ROI analysis originates from a commercial business context and is meant to find the direct financial return to an investor, gained as a result of the financial investment. In public health, ROI analysis is similar to benefit cost analysis, except it typically is limited to only the perspective of the entity paying for the intervention, rather than assessing the benefits and costs of the intervention from a larger perspective, like a societal perspective. As such, a return on investment analysis typically relies on short-term returns to the payer and often ignores the full range of benefits of an intervention, like the health of the beneficiary, if they do not accrue to the payer. There are several limitations to return on investment analysis. First, incentives for the private sector are often different from those from the public health perspective. For example, case management might be a good method for improving outcomes, but health insurance companies may not reimburse for case management. Second, although some interventions to improve cardiovascular disease outcomes have been effective in workplace settings, there's no incentive for the employer to invest in prevention if the workplace has a high turnover rate and the potential cardiovascular benefits won't be realized until far in the future. Finally, return on investment analyses are limited because other sectors, such as Medicaid and Medicare or the individual, may benefit from the intervention, but these benefits are not included in the analysis, since it is only taking the perspective of the investor paying for the intervention. Common applications of return on investment analysis in the field of cardiovascular disease include disease management programs and worksite health promotion programs. The latter have typically shown positive returns within 5 years, which is appropriate for a business model, with returns outweighing costs. Let's look at an example of a return on investment study for a workplace health promotion program. To evaluate the workplace health promotion program, the authors studied the employees' health risks and healthcare costs between 2002 and 2008, during which they participated in the workplace program and compared them to employees at similar companies as a control. They found that employees in the health promotion program over this period demonstrated lower health risks and lower healthcare costs. This saved the employer an annual $565 per employee in employer-provided healthcare. Because the employer was the payer of the intervention and realized a financial gain as a result of the program, they were able to calculate the ROI to the employer from investing in the program. It ranged from a $1.88 to $3.92 return for every $1 spent. This is a good example where the payer of the intervention received financial gains as a result of public health investment, and thus could use ROI to make a strong business case. However, if the payer were not the employer and did not receive those savings in medical costs, there likely would not be enough of a financial return from that perspective to show a positive ROI. In that case, a different evaluation method might be better suited to show the intervention benefits.